Hi, welcome back. This is part 2 of fluid balance and electrolytes, and we're going to discuss electrolytes. So the key electrolytes that you should memorize for school are sodium, potassium, calcium, magnesium, phosphate, and chloride. The two I want to focus on with you today are sodium and potassium. So when you think about sodium, the first thing that you should think about is the brain and the nervous system, because sodium has a really key role in exciting our neurons. So when you have a change in sodium in the body, the sign and symptoms you're going to see are going to be neurological. So serum level is going to reflect a ratio of sodium to water in the body. So keep that in mind, because when you have either a depletion or an excess of sodium, it can be either due to a water loss or a water gain as well. So it's a ratio, so just keep that in mind. So let's talk about hypernatremia first. The normal sodium reference range is 135 to 145 milliequivalents per liter. And just remember that when you go to the hospital, they might have a slightly different reference range, and that's normal, but for the purpose of school and your tests, just remember those numbers. Hypernatremia is going to be either due to a loss of water or a sodium gain. It can be both at the same time as well. Signs and symptoms are going to be agitation, lethargy, weak, seizures, and can even lead to coma. And if you have hyponatremia because of a water loss, it could be due to diabetes insipidus, which we talked about in part 1, where ADH plays a strong role in water retention. And if you have diabetes insipidus, you actually have an excessive diuresing of water. And so you're going to show signs of hypernatremia because of a water loss. If you have hypernatremia because of an increase in sodium retention, it could be due to things such as a fluid infusion, IV fluid infusion. Okay, so moving on to hyponatremia. Hyponatremia is a lot more common than hypernatremia and is going to be a reference range below 135 milliequivalents per liter. And again, it's a ratio of water to sodium, so it can be either due to a water gain or a sodium deficit. It's a lot more common because the causes of hyponatremia include your GI issues like diarrhea and vomiting, NG suctioning if it's really, really frequent. These are going to cause excessive electrolyte losses in the body. Diuretic therapy and burn victims also have a big issue with hyponatremia. And also getting into our disease processes, syndrome of inappropriate antidiuretic hormone, SIADH, which we discussed earlier, is an excessive increase in water retention. And also heart failure causes high water retention and can cause hyponatremia. Signs and symptoms of hyponatremia, again, think about your brain and your nervous system. You're going to see your patient get irritable, confused, possible headache if it's due to water gain, and again, seizures, and can lead to coma. And I just want you guys to remember that if your patient has a change in fluid volume, as well as a shift in their sodium, whether it's an increase or a decrease in sodium, you're going to see the same signs and symptoms of that fluid volume excess or fluid volume deficit that we talked about, as well as the signs and symptoms of either the hypo or the hypernatremia. Okay? So that's sodium. Let's go on to potassium. So when you think about sodium, you're going to think about the brain and the nervous system. When we think about potassium, I want you to think about muscle and heart. Potassium is mainly kept inside of our cells, especially muscles. The reference range for potassium is 3.5 to 5 milliequivalents per liter. And again, this is the same as sodium. We're testing the serum. And just to give you an idea of how important potassium is inside the muscle cells, the reference range for muscle potassium inside the muscle cell itself is about 140 milliequivalents per liter. So it's a lot greater. So remember that potassium is kept inside the cell and has an inverse relationship with sodium. So let's look at hyperkalemia first. This is going to be if you have a patient that has a value over 5. And a shift is going to occur. And if you have a value over 5, you have hyperkalemia. Potassium is leaving the cell. This is going to be either caused by renal failure, It can be caused by burn and crush injuries. And potassium-sparing diuretics or ACE inhibitors also help cause the body to retain that potassium that it would normally excrete through the urine, as well as metabolic acidosis, because the hydrogen ions in metabolic acidosis are basically trading places with the potassium in the cell, and the potassium leaves the cell, and then you have hyperkalemia. So the signs and symptoms we're going to see with hyperkalemia include irritability and anxiousness, cramping and diarrhea. Again, cramping, think about that muscle issue that we're having. And on the topic of muscles, because it's hyperkalemia, the first muscle signs that we see are actually in the legs. As the process progresses and you have continued hyperkalemia, then you're going to start to see your cardiac issues and your cardiac arrest. It can lead to a lot of EKG problems, changes, and an irregular pulse. I'm not going to get into detail about the EKG changes. You should look those up though. They're very specific, and I didn't want to bog you down with that, but definitely ECG changes. So going on to hypokalemia, you're going to have a value of under 3.5, and again, this is testing the serum. And if you have hypokalemia, this changes the resting potential of your muscle cell, and it affects its ability to contract. So you have a decreased excitability of the cell with hypokalemia, which means the shift from the extracellular fluid to the intracellular fluid, and you're going to have a loss. So this is caused by diuresing because of an increase in aldosterone, which means that sodium is saved and potassium is lost. That's the inverse relationship I was talking about. Diarrhea, vomiting, and laxatives can cause a large loss in potassium. And just like metabolic acidosis can cause hyperkalemia, metabolic alkalosis can cause hypokalemia. The hydrogen ions are going to shift into the cell. The potassium ions are going to leave the cell. The hydrogen ions are going to shift out of the cell, and your potassium is going to shift into the cell. DKA treatment causes hypokalemia, as well as insulin. If you're administering a lot of insulin to a patient with diabetes, insulin causes a shift of the potassium from outside of the cell to the inside of the cell and can cause hypokalemia. So signs and symptoms for hypokalemia include fatigue, muscle weakness because of that change in the resting potential of the muscle, and again, leg cramps. You're going to see issues with leg muscles before you see cardiac issues. And also think about smooth muscle issues. So you're going to see, it's going to affect respiratory muscles. You might see difficulty breathing, an increased respiratory rate, as well as you can see a paralytic ileus if it progresses too far. Again, the ECG changes, and ventricular dysrhythmias are very common with hypokalemia because of that resting potential change. So that is our review for potassium and sodium. Just to sum it up, I want you guys to remember when you think sodium, I want you to remember brain and nervous system. When you hear potassium, I want you to think muscle and heart. Remember your reference ranges, and good luck on your testing.